Welcome back to the final session of the day, and we are on the way to complete neurology, and only very minor topics are still left. All right. So if you can hear and see me, you can tell yes, probably, so that we can start the session. Okay, fine. You can hear and see me. Cool. So let us start with our discussion. And once Alzheimer's is over, the dementia becomes relatively simple because other types of dementia are relatively rare. And the second type of dementia we're going to discuss is on the frontotemporal dementia. That is basically on something called as a frontotemporal neurocognitive disorder. Currently, that's called FTMTD. That's a frontotemporal neurocognitive disorder. So how can I classify this frontotemporal neurocognitive disorder? You can classify basically into two types. One is the behavioral variant and one is the speech variants. And of course, this frontotemporal neurocognitive disorder typically happens in relatively younger population. So Alzheimer's patients will have a relatively older age, but these patients are going to be relatively younger in their nature. Clear? So that's how they're going to be. And more importantly, they're going to affect the frontal and the temporal lobes. With the relative sparing of the parietal lobes, they're going to typically affect the frontal and the temporal lobes only. They don't affect the parietal lobes that much. So that's also very important to understand. So in that, I can tell you what are the problems that the patient is going to have because of involvement of the frontal lobe. And I can also tell what are the problems that these patients are going to have because of the relative impairment of the temporal lobe. Remember, apart from Alzheimer's disease, which typically affects memory, other neurocognitive disorders will not have memory loss as a major finding, even though they can have memory loss. But memory loss is not a very, very important feature as far as the other neurocognitive disorders are concerned. Even in frontotemporal dementia or frontotemporal neurocognitive disorder, memory loss is not going to be the prominent finding in this setting. So as far as the frontal lobe is concerned, the problem is going to be more in the executive dysfunction. I'll tell you what do you mean by executive dysfunction sometime. Apart from that, they will have a lot of behavioral issues like apathy, then disinhibitory behavior because frontal lobe is affected. So behavioral issues will be there. I think I told you the prefrontal cortex is the seat of inhibition, social behavior. So if it's lost, they can result in disinhibition, or sometimes you can go for apathy and poor thinking and all this stuff. The temporal lobe is affected. There are two things that temporal lobe will be involved with. One is the language, we know that. And second one is going to be your memory. Even though memory impairment is not very prominent in frontotemporal dementia, still it can happen. And as far as the language is concerned, there are many different types are there. Like we have non-fluent aphasia variant, which will mimic a little bit of Broca's-like picture. And you can have a semantic or a fluent aphasia variant. Semantic or fluent aphasia-like variant. So this will mimic something like Wernicke's, not all the features, but something like Wernicke's will be there. So these are basically the different types. So based on the two lobes involvement, frontal and temporal lobe, you can have this kind of issues. And remember, more importantly, even if the temporal lobe is affected, the most common area in the temporal lobe that is affected is the anterior temporal lobe, not the medial temporal lobe. And there will be relative sparing of the medial temporal lobe because temporal lobe involvement, that medial temporal lobe involvement is very classical of a Alzheimer's disease, the first site to involve in Alzheimer's disease. But in frontotemporal neurocognitive disorder, the anterior temporal lobe is the one that is going to be very commonly involved compared to that of the medial part of the temporal lobe. Okay. Then we also have the different types, as I told you, based on which area is predominantly involved. Whether it's the frontal lobe or it's the temporal lobe which is predominantly involved. Based on that, we can give different types of frontotemporal dementia. In that, I'm going to start with something called a behavioral variant. So I'll put two variants here. One is the behavioral variant. And this is supposed to be the most common variant of frontotemporal neurocognitive disorder. That's called a behavioral variant. And then we have the speech variants also, or we can call it as language variants or speech variants. If they ask you an exam, what is the variant that is extremely common in frontotemporal dementia? I'll be answering behavioral variant only. Language variants are comparatively less common. So here the predominant problem, as I told you, will be in the frontal lobes. Frontal will be the predominant problem. Here, most of the problems will be located in the temporal lobe only. But remember, in the anterior temporal lobe, not in the medial temporal lobe. As far as the behavioral variants are concerned, so the most important problem will be disinhibition in these patients. Disinhibition in the sense, we know it might translate into a kind of an antisocial behavior also, but disinhibition, very important, like impulsive behavior and very inappropriate behavior. Like an example I told you, if I go to pee in the screen and come back and sit and take the class, so that's an inappropriate behavior. So this is what we mean by antisocial behavior or disinhibitory behavior. And they can have severe apathy and abulia. Abulia means difficulty initiating a thought. So an extreme form is what we refer to as apathy. And they will also have loss of sympathy, in the sense like they won't have any kind of sympathy, and that can also translate to a disinhibitory or antisocial behavior. Sympathy, empathy will be lost. Once again, it's an important function of a prefrontal cortex. And number 4 is they can result in development of something called a hyperorality. Like for example, a binge eating, increased consumption of socially unacceptable products like alcohol, cigarettes, and all this stuff. And even this can start in eating mud, which is called as pica. So that's possible. So that will come under hyperorality. And because of that, you will encounter a lot of dietary changes in this patient. So this will be the clue in exam. So this kind of disinhibitory behavior, hyperorality, dietary changes, eating, nonsense stuff. So this is what is going to be the classical features of behavioral variant. As far as the language variant is concerned, we call them as progressive primary aphasia. And the most important area that will be affected in language variants is the temporal lobe. That's where the involvement is going to be. So as I told you, you're going to have 3 different types in this. One is called a non-fluent aphasia, otherwise referred to as a progressive non-fluent aphasia, also referred to as a agrammatic type of aphasia. So where predominantly it will mimic like a Broca kind of a picture, where they'll find problems in speech output. The fluency will be lost, and they can, of course, they will have naming issues. Anomia will be there, and they might have this word finding difficulties. In fact, like when they want to tell something, they'll not be able to tell. So they will search for that word. What word should come at that point? So they cannot get that word properly. Word finding difficulties. We all get in viva vocis, isn't it? So this kind of word finding difficulties are very common in the setting of a non-fluent aphasia. So you can imagine a person who's going to answer, maybe a boy who's answering a viva voce is going to behave like a non-fluent aphasia. Word finding difficulties and poor articulation, difficult speech, labored speaking, as if they are trying to speak in a very tough manner. Like it becomes very incredibly tough for them to speak. So it's called labored speech. And naming difficulties, typically a boy who's presenting to a viva voce. And what about this other variant? That's called a fluent aphasia, otherwise referred to as a semantic variant. Fluent aphasia and semantic variant. This will be like, for example, a girl who's going to viva voce. You can imagine like that, where the girls is going to use words like thing, stuff. So, like they will be too much, like it look like as if they are having a normal fluency, but they tend to manipulate in between. They tell a lot of wrong things, but since the examiner is more concentrating on the girl than what she's trying to say, they try to say a lot of stuff. And examiner is the one who gives most of the times this kind of boost to the girls, isn't it? So they will tell, come on, ma, yes, what you're telling is right. So the girl becomes too much happy, and she starts telling like this kind of stuff, which is not even in the textbooks. So that's basically like kind of a semantic variant or a fluent variant, where there will be comprehension problems, typically to an extent like Wernicke's, but not exactly Wernicke's. Comprehension difficulties will be there, and but intact repetition. For example, if examiner tells something, you tell the same thing again. So repetition may be there, and again they'll be doing a lot of repetition in between, and many generalization also can be there. Like, for example, they will use a word called thing, very common. Instead, that's an example. So where they don't use the exact word. For example, if I use pencil or pen, this is an exact word for this. But if it's this thing, I'm going to write, and I'm going to write on this particular thing. So this kind of generalization will be there. For example, if you show a dog photo, and if you ask what is this, they'll be telling animal, not a dog. I mean, you have to tell it's a dog, but they will tell it's animal. So this kind of generalization will be there. This is again very classical, not classical of Wernicke's, but still can happen in setting of a frontotemporal dementia, especially the fluent and the semantic variant. Third variant, which is coming up now, right now, is the logopenic variant. logopenic progressive aphasia. Here the main problem will be repetition difficulties and naming difficulties. So non-fluent output will be the main problem. Okay, this is the most important problem in non-fluent aphasia. And as far as semantic variant is concerned, the comprehension will be the most important problem. And most importantly, the generalization, as I told you, that's going to be the key here for diagnosis. And at the same time, as far as logopenic variant is concerned, the repetition loss. Repetition will be the most important problem here. It will be lost. And all these three are going to have naming difficulties. Naming difficulties will be there in all these three things. So repetition will be lost here. That's the primary problem. Comprehension and generalization. Comprehension loss and generalization is the primary problem here. And output, articulation, very labored speech. That's a characteristic feature of a non-fluent aphasia. Nevertheless, in exam, how will you make out this frontotemporal dementia? A young patient around probably 50-55 years. So a young patient coming with more of a word finding difficulty, language issue, think about a frontotemporal neurocognitive disorder. Or if a young patient coming with more of a behavioral issues to start with, so think of a frontotemporal neurocognitive disorder. Remember, amnesia happens late in the setting of a frontotemporal neurocognitive disorder. And at the same time, memory is relatively spared in the setting of a, sorry, not memory, I'm talking about other domains like calculation. And all these things are relatively spared. For example, even drawing is relatively spared in the setting of a frontotemporal neurocognitive disorder, because calculation, drawing are all functions of the parietal lobe, not the functions of the frontal lobe. So that's why they are spared. And as far as the investigations are concerned, typical diagnosis through brain biopsy only, but that is completely unnecessary. So you are going to diagnose clinically only. But there are some genes that are affected, I mean, which we didn't discuss. So a gene called TDP53 gene is there. TDP43 gene is there. That's called a TARDBP gene, TARDBP. But simply you can remember as TDP43 gene. Then you have a gene called proguanil gene that is probably involved in frontotemporal dementia. Then you have MAPT gene. This is for tau protein. This is for the production of tau protein. So MAPT gene can be involved, and we have another gene called VCP gene. So these are the usual genes that are involved in the development of frontotemporal neurocognitive disorder. As far as the investigations are concerned, I can do imaging, as I told you before, to rule out other causes. Then SPECT can be done, where I will see hypoperfusion in the frontal lobes and the temporal lobe. But in the temporal lobe, anterior part of the temporal lobe is the one that is going to be mostly affected in the setting of a frontotemporal neurocognitive disorder. Suppose if you do a biopsy, the most important point is you will not see NFTs, you will not see A-beta amyloid blocks, which clearly tells you that it is not Alzheimer's disease. But on the other hand, you might see some tau inclusions. Remember, these are not hyperphosphorylated tau proteins, so that should not be called as NFTs, and the morphology will not be similar to that of NFTs. But these tau inclusions that you see here are referred to as PIC bodies, because they don't look like NFTs, and at the same time, they're not due to hyperphosphorylated tau proteins. So these are called as, by a separate name, called as PIC bodies. And you can develop, and you can see this inclusion bodies in the form of TDP43 inclusion bodies. These are two inclusion bodies you generally see in the setting of a frontotemporal neurocognitive disorder. Remember, it is the fourth most common cause of dementia, not the first most common. First most common is always Alzheimer's disease. And it's the most common cause of dementia in younger patients, less than 65 years of age. After 65, of course, Alzheimer's is going to the most common. That's why I told you relatively younger, 50s and 55s. Most common cause of dementia in younger patients, less than 65 years. And treatment, you're going to use the same treatment as that of what you use for Alzheimer's disease, even though the response is very limited. You don't get a good response in the setting of a frontotemporal neurocognitive disorder. Then we have dementia with Lewy bodies. Currently, we'll call it as NCD with Lewy bodies, neurocognitive disorder with Lewy bodies, or dementia with Lewy bodies. And remember, even though it's called as dementia with Lewy bodies or NCD with Lewy bodies are seen only in 30 to 35% of the individuals. It's not seen in all the individuals. What are the characteristic features? Remember, once again, memory loss will not be a major problem here. In fact, memory will be spared in NCD with Lewy bodies. Most of our patients will have a very good memory, in fact, but other cognitive domains will be affected. For example, attention will be the most important problem in this, and second is executive function. Attention and executive function are the two things that will be severely impaired in the setting of NCD with Lewy bodies. And second thing, the most important clue is visual hallucinations, and there'll be complex and formed visual hallucinations most of the time. So this is the reason why these patients can be mistaken as psychosis also, because it's not a psychosis, because psychosis insight will be impaired, but this is a NCD only, so insight may be still there, so that differentiates it from a psychosis. But this visual hallucination is the very important keyword for diagnosing NCD with Lewy bodies in the exams. And of course, at least one of the Parkinson features will be there. At least one of the Parkinson's clinical features will be there. You know what are the Parkinson's features? You have tremors, akinesia, rigidity, and you have postural dysfunction. So we'll be discussing about in some time. So one of the Parkinson disease features will be there, like bradykinesia, tremors, or rigidity. At least one Parkinson feature will be there. And number 4, they can have REM sleep behavioral disorder. REM sleep behavioral disorder. This is very characteristic of Lewy bodies, in fact. It can happen even in Parkinson disease, because even Parkinson, some of the cases are due to Lewy body formation. So there is some association with Parkinson anyways. That's why some patients with Lewy body dementia also has associated Parkinson features. So one of the important features of this Lewy bodies is the REM sleep behavioral disorder, which can happen in Parkinson also. I'll be telling that time as well. And Lewy bodies are aggregates of alpha-synuclein, we know that. And these are also intracytoplasmic inclusion bodies. And they're eosinophilic in nature. Intracytoplasmic eosinophilic inclusion bodies. Remember, A-beta amyloid plaques are eosinophilic, whereas neurofibrillary tangles are basophilic. Alpha-synuclein, that is Lewy body formation, is again intracytoplasmic and eosinophilic inclusion bodies. And number 5, apart from this, they have extreme sensitivity to neuroleptics. That's a very important word. Extreme sensitivity to neuroleptics. Why? Because already they have Parkinson features, and top of that, if you give a neuroleptic drug like haloperidol, it's an antipsychotic. Dopamine blockers are what we call as neuroleptics. They will significantly worsen the Parkinson feature, and the patient is going to suffer a lot. And the patient may be frozen completely, and the rigidity, tremors, and bradykinesia will worsen a lot. And that's why it's called as extreme sensitivity to neuroleptics. And they may even progress to a stage where they can develop a neuroleptic malignant syndrome also. And that's very dangerous. So that's why you should avoid using this neuroleptics in this. And why we commonly use neuroleptics is because many times as a beginner, some psychiatrists may diagnose this as a psychosis because they have visual hallucinations. For that, they might start haloperidol, and that results in a catastrophe because patients will start developing severe Parkinson features after giving. So that's what we call as extreme sensitivity to neuroleptics. And treatment as such, see, that's the 6th point. You're going to give rivastigmine. Rivastigmine is one of the best treatment. In fact, any acetylcholinesterase inhibitor works, central ACH inhibitor works, like what we use for Alzheimer's disease. But rivastigmine has the best response among all. In fact, rivastigmine works better than your Alzheimer's disease here. So that's a very good treatment, very good therapy for dementia with Lewy bodies, NCD with Lewy bodies. So the exam clue will be mostly the visual hallucinations. Any patients with NCD and visual hallucinations, think about Lewy body dementia. Remember here, memory is spared. In the sense like there will be no problem in the memory at all. That's why I told you, apart from the Alzheimer's disease, most of the other cognitive dysfunctions will have a reasonably spared memory, or you can have even a normal memory most of the times. So then next one is the vascular dementia, or otherwise as vascular neurocognitive disorders. Typically, it is due to vascular events like a large stroke, due to large vessel infarction, or it could be due to multiple lacunar infarcts. That is happening again and again. Multiple lacunar infarcts. That's happening again and again. So anything that can result in damage to the basal forebrain. So that is going to result in a vascular neurocognitive disorder, previously called as vascular dementia. So the key features of vascular dementia in exam is this typical step ladder pattern of deterioration. That's what is suggested. But remember, there can be a slowly progressive decline. In fact, this is supposed to be the most common. But the step-ladder pattern of deterioration is what is very commonly asked in exam and very characteristic feature of a vascular neurocognitive disorder. So that's why this is being thought to be very important. But on the other hand, currently it's believed that this progressive deterioration is the most common entity as far as vascular neurocognitive disorder is concerned. And of course, it's going to be stroke, due to stroke. So how will you differentiate this from other dementia? Remember, any neurocognitive disorder with typical UMN signs, with early onset UMN signs, typical and early UMN signs is equal to vascular dementia or vascular neurocognitive disorder, vascular NCD. So anyone with UMN signs, typical UMN signs, XLDTRs, Babinski positive, in exam you can always think about a vascular entity. So when you think about the step-ladder pattern, UMN signs and a dementia, remember in Alzheimer's disease, to get a motor problem, it takes a very long time. But in vascular dementia, you get UMN signs much faster, early. At the time of presentation itself, they will have significant UMN signs. That's an important feature of a vascular dementia. Treatment-wise, you can use anti-dementia drugs, which I have told you before, but it's not going to work that much. But nevertheless, you can give. And at the same time, you have to prevent subsequent stroke, because at every vascular event, they deteriorate further and further and further. That's why that classical step-ladder pattern of deterioration is there. So to prevent the further strokes by giving proper secondary prophylaxis to these individuals and risk modification. I told you, just now. So at every event, they have this step-ladder pattern of deterioration. They will be stable over a long period of time. Then again, they will get worse in their cognitive performance. Then again, after some time, they will worsen. They will be stable for some time, and again, they will worsen this cognitive domain function testing. So that's how you diagnose a step-ladder pattern of deterioration. And that's classical of a vascular type of neurocognitive dysfunction. So we had all these things, fine. And I mean, we didn't discuss about the infectious form of neurocognitive disorder, that is Creutzfeldt-Jakob disease. This is a very important cause of dementia. There are many types of Creutzfeldt-Jakob disease, like sporadic Creutzfeldt-Jakob disease, variant Creutzfeldt-Jakob disease. Many different types are existing, but sporadic is the most common. Almost 85% of the Creutzfeldt-Jakob disease will be sporadic in nature. First of all, you need to know the age in sporadic. Age will be usually more than 50. And only 2 points that you need to know. One is RPD, that is rapidly progressing dementia. Move down. Okay. One is RPD, that is rapidly progressing dementia. Rapidly progressing dementia in the sense you will have dementia within 6 months. All the domains of cognition will be affected within a period of 6 months. So this is what we refer to as something called a rapidly progressing dementia in this setting. Plus, the patients will have motor problems like myoclonus, even though they can have a lot of behavioral issues. But whenever these two things are present in exam, rapidly progressing dementia with myoclonus, that is equal to Creutzfeldt-Jakob disease unless proved otherwise. That's all. That is Creutzfeldt-Jakob disease, as simple as that. And this is the clue. And of course, investigation-wise, the best investigation is brain biopsy only. That's the gold standard to find out these prion bodies. But we don't anyway do that investigations. Instead, we try to diagnose based on MRI. In MRI, you see two classical signs. One is called cortical ribboning, and second one is called a hockey stick sign. Hockey stick sign, and third one is called the pulvinar sign. So all these signs have been asked in exams. Hockey stick sign, pulvinar sign, cortical ribboning. All these are classic findings in MRI. Cortical ribboning is very commonly seen in SCJD, and hockey stick sign and pulvinar sign is commonly seen in VCJD, variant CJD. But nevertheless, all these are important for exams. And if you do an EEG, again, very classic in a sporadic Creutzfeldt-Jakob disease, like you can see this kind of slow background. The entire background will be slowed, but there will be periodic sharp waves here and there. There will be periodic sharp waves. This is very classical of a sporadic Creutzfeldt-Jakob disease again. In variant Creutzfeldt-Jakob disease, you cannot predict what you will see, but in a sporadic Creutzfeldt-Jakob disease, this is the classic finding that you will see. And as far as CSF is concerned, there is one protein that is very important, that's called a 1433. This doesn't have any special name, that will be increased. So That's a many times asked question. 1433 increase. Remember, this is a non-specific protein, but it becomes specific at certain entities because it's a kind of a neural injury sort of a protein, which means any neural injury can cause elevations of this 1433. So if you have ruled out any acute causes like infarcts, trauma, bleeding, if you rule out all these things, so if you don't have any background issues, still if 1433 is elevated, then that time it can become a little specific for Creutzfeldt-Jakob disease. Apart from that, it's found to be a marker of a severe neural injury. That's all. So EEG is over. And as far as the treatment is concerned, there is no treatment. You don't have any treatment for Creutzfeldt-Jakob disease. Invariably, the patient is going to die, and the median survival in the setting of sporadic Creutzfeldt-Jakob disease is only 8 months. Irrespective of whatever treatment you give, they're going to die within 8 months. Variant CJD, very, very rare disease. It's not common. Only 5% can have variant CJD. And usually age will be less than 30 to 35. Very young age. So variant CJD. Apart from that, many things can overlap with variant CJD, but more often they'll come with a behavioral issue. And it's a very rare disease. So no need to bother much about it. So usually in exam, your SCJD will be the question. And you know what's going to happen in the setting of Creutzfeldt-Jakob disease. It's a prions disease. So normally, you know, prions are in the form of, the form of PRPC configuration, which is an alpha helix configuration. This is a normal prion protein. And we really don't know what is the function of a normal prion protein, but still it's present in all the cells. But this normal prion protein, due to some reason, it becomes something called PRPSC. That's called a scrapie form. SC stands for scrapie here. So once they become this PRPSC form, they get arranged themselves in beta pleated sheets. And what they do is, how much ever times they ask, this PRPSC is just a protein, that's all. But this is one of the medical enigmas, how this protein is able to infect other proteins. In the sense like this protein, once they form, they cause conversion of this PRPC to PRPSC. Once again, more PRPSC. This will again act on the PRPC to produce more PSC. So this is looking like some sort of a virus and a cloning, isn't it? So the same once PRPSC protein is formed, so they keep, like this kind of vicious cycle, and they convert more and more PRPC to PRPSC, which means it's like a protein infecting another protein. That's very enigmatic, and it's looking like a virus, but it's not. It's a protein only. How many ever times they ask in exam, I can surely tell it's a protein only. It's definitely not a virus. It behaves like a virus though. That's one enigmatic thing about this prion protein. Fine. So this is about CJD. As far as CJD is concerned, rapidly progressing dementia with myoclonus is equal to CJD unless proved otherwise. That's all. Fine. So I think we have discussed about almost all the dementias as of now. But now let us summarize, because it will be very tough otherwise to diagnose in exam. So first is Alzheimer's disease. What will be the clinical features of Alzheimer's disease? Usually the most important thing is the slow progression, age more than 65 years, and predominant memory defects. Amnesia is the most important problem. Plus or minus behavioral issues later on, but this is going to be the most important. And you will see ex-vaco kind of an hydrocephalus in MRI, otherwise completely normal imaging, or SPECT may show reduced perfusion in the temporal lobes and probably parietal lobes, especially in the temporal lobes, in the medial temporal lobes. And PET, that I told you, Pittsburgh compound B, PAB. So that could be a future, but still only the name is important right now. Treatment is acetylcholinesterase inhibitors like donepezil or galantamine, and you're going to use NMDA receptor agonists like memantine. This is going to be the treatment. As far as your frontotemporal neurocognitive disorder is concerned, the patient is going to be less than 65 years, relatively young in exam, and predominantly behavioral issues like antisocial behavior and all this stuff, and they'll have language problems, language issues. But memory is not a very important problem here. So in this setting, investigation wise, you can do SPECT, where you can see decreased perfusion, but this time it's in the frontal lobe and the temporal lobes, and typically in the anterior temporal lobe, not in the medial temporal lobe. And treatment, we don't know. Same treatment you can try, but it doesn't work generally. And inclusion bodies, anything I can write here separately. Is there any? This is the treatment, this is the clinical feature, and this is the investigation. As far as inclusion bodies is concerned, Alzheimer's disease, A beta amyloid and neurofibrillary tangles, which are nothing but hyperphosphorylated tau proteins. And inclusion bodies here, you can see PIC bodies, and you can see TDP43, and you can see FUS. There is another inclusion body, I forgot to tell, that is FUS is also there. PIC bodies are basically tau inclusion bodies only. And you have a dementia with Levy bodies. I can write DLB, or you can write as NCD associated Levy bodies. Age can be anything, but the most important clue will be visual hallucinations. Parkinson features. And patients having attention deficit. Predominant problem will be attention deficit and executive dysfunction. So in that setting, you're going to diagnose Lewy body dementia. The treatment is acetylcholinesterase inhibitors and rivastigmine, especially in that group. That's going to be very important. Investigation-wise, you don't have much investigations to do here. And as far as inclusion bodies are concerned, you're going to see Levy bodies. Levy bodies. It's alpha-synuclein bodies. Vascular dementia or vascular neurocognitive disorder. You'll be typically having human signs in a patient who's having cognitive dysfunction, prominent human signs, and the characteristic step ladder pattern of deterioration. MRI is very, very important here, where you want to find out the infarcts, either a big infarct or a multiple lacunar infarct, especially involving the basal forebrain area. So that's a sign here. And again here, memory loss will not be a problem. The main problem will be attention and executive dysfunction. That's going to be the most important problem. And treatment-wise, you can try drugs, but prevent further strokes. Prevent further strokes by giving a good secondary prevention, like clopidogrel, aspirin, and all this stuff. And possibly no inclusion bodies here. And finally, you have a CJD. The clue will be rapidly progressing dementia plus myoclonus. So if you see these two in exam, it's always Creutzfeldt-Jakob disease at any cost. Investigation wise, you can see MRI, where you know you're going to what you're going to get, that kind of signs we discussed already: cortical ribboning, pulvinar sign, hockey stick sign. You can have CSF 1433 or EEG. You can see that sharp waves, slow background, the periodic sharp waves. So characteristic again of Creutzfeldt-Jakob disease. And treatment, treatment wise, you don't have any treatment. Like as far as the biopsy is concerned, you can see these spongiform changes. That's why the original name for Creutzfeldt-Jakob disease is spongiform encephalopathy. If it's due to eating cows, that is called a bovine spongiform encephalopathy, BSC. So these are the 5 important dementias or 5 important neurocognitive disorders that you need to know for exams. This final table, whatever given, will be very useful for you in exam. Before going for exams, the revision purpose, this table will be very useful. So you just go through this table and go. Clear? Do you understand? So that we can move on to the next one. Clear, right? Actually, to be honest, I always feel that neurocognitive disorders are very difficult to explain to a student because they have not seen. As simple as that. That's the one reason. Plus, it's like a kind of an implicit memory. It's non-declarative. It's very difficult to explain what you really see in the patient. But nevertheless, I've tried to make it as simple as possible. And the final table is very important. Just read that and go for exams. And apart from that, what else is there? Yeah, we have meningitis. We can discuss on that aspect. Meningitis or probably meningoencephalitis, very important. And of course, the usual reason for development of meningitis, most common organism, if they ask you, of course, it's going to be pneumococcus only, Streptococcus pneumoniae. That's also the rationale for vaccinating with pneumococcal vaccine almost all the people, because they are prone for meningococcal meningitis. And there are many different strains are also there, which I'm not going to discuss right now. And apart from that, if they ask you where you will develop meningococcal infection, Meningococcal infection is very common in adolescents, especially when they move to the dormitories and hostels. Especially in exam, if you get a student, school student who has completed the schooling and went to a different area, to a hostel for accommodation, that moment, so during that time, if you get a meningitis, very commonly it will be a meningococcal infection. So meningococcus, this adolescents, teens who are moving out of the house and going to a hostel, so that is the time where you get meningococcal infection. Apart from that, most of the adult patients will be having meningitis, most commonly due to pneumococcal infection, that is Streptococcus pneumoniae. Nevertheless, you can get staphylococcal meningitis also, like when you suspect Staphylococcus pseudomonas, when there is a procedure that's being done. For example, if it's a ventriculoperitoneal shunt, or you done some craniotomy, any neurological surgery, and after that, if you get a meningitis or a meningoencephalitis, that is likely to be staph or pseudomonas, hospital acquired. So probably. Apart from that, organism-wise, listeria is very important. Listeria is the most common cause of rhomboencephalitis in the world till now. So they cause a peculiar entity called rhomboencephalitis. And listeria can be suspected in extremes of age. For example, extremely younger age, like infant or like newborn child, or you can think about in very old age, like more than 65 years, 70 years. Extremes of age, you can think about listeria. But in general, we give listerial prophylaxis after 50 years of age, or if patient is HIV or some other immunosuppression is there, you can think about listeria. Then there is another organism you can think about, that is nocardia. Typically in post-transplant setting, you can think about nocardia also, even though other organisms are common. But in exam, notoriously, if the examiner gives a kind of brain abscess that is not responding to your routine antibiotics, then in that setting, you can go for a nocardia as the answer. So as far as the organisms are concerned, most of the adults, it will be pneumococcus. As I told you, these teens and these young adults who are moving out of the home into some new hostel, that time you can suspect meningococcus. Then if it's a post-neurosurgery, then you can suspect Staphylococcus, Cons or Staph aureus, or you can suspect a Pseudomonas in this setting. Or if the patient is having extremes of age, especially elderly, extremes of age, especially age more than 50, or immunosuppressed, like HIV. In this setting, you can think about a listeria, listerial meningitis. Remember, listeria is the most common cause of rhomboencephalitis in the world. And at the same time, post-transplant, in exams, think about nocardia. I'm not telling always nocardia. You have to think about common organisms also. Plus, along with it, you can think about nocardia if they are not responding to common antibiotics. Because nocardia is acid fast. We know that. So, notoriously, an examiner might give the CSF may show some acid fast organisms also. In that, don't think about TB if it's a post-transplant. You can think about nocardia. That's very important as well. So these are the usual reasons for meningitis. Remember, meningitis will not have typical focal-neurological deficit, no FND. If it's only a meningitis, you should not get FNDs, and they'll be having very minimal cortical symptoms and signs. Cognitive dysfunction will not be that severe in the setting of a meningitis. Suppose if you have an encephalitis, in this setting, you will have an associated focal-neurological deficit like cranial palsies and all this stuff, and there will be severe cognitive dysfunction. There will be more cortical symptoms and signs. More and more cortical symptoms and signs, and presence of focal-neurological deficit usually goes towards a encephalitis. So which means in the setting of meningitis, and you have an encephalitis also, that's called meningoencephalitis. Clinically, it's very difficult to diagnose them, but you need other imaging techniques also. And apart from that, if you think about a virus, there are many viruses that can cause encephalitis and meningitis. But if you think about a virus, always think about herpes simplex virus. That's the most common virus that is a known cause of viral encephalitis. Most common, like identifiable cause of viral encephalitis is herpes simplex encephalitis. And whenever a patient is suffering from HIV, you have a variety of causes. Like it can be due to listeria. Listeria can cause rhombencephalitis, or infection can be from Cryptococcus meningitis. Cryptococcal infection is there. So that is also one possibility in this setting. So you have to think about cryptococcal meningitis as well. So many infections are there, but this is what we commonly think. Even TB can be there, but like where we diagnose TB, I'll tell you in some time. So fine. So we have known some of the few organisms that can cause meningitis. Now, how to evaluate a patient with meningitis? So first, when we suspect, when a patient is coming with fever, headache, altered mental status, then if the patient is having neck stiffness, the patient is having focal neurological deficit, cortical symptoms and signs. These are stated so you cannot write. So the patient is having photophobia. So common feature will be fever and a headache. So this will be a common feature. Other things are plus or minus sort of a thing. So usual will be fever and headache. That's going to be most important. In this setting, I'm going to definitely suspect a meningitis or probably even a meningoencephalitis. I'm going to suspect. Once I suspect, next see the patient is having FND or not. Just hold on, I'll come back.